Today I'm here speaking with the wonderful Dr. Sacha Howell and Dr. Sarah Hindmarch about the BCAN-RAY study, which is looking into breast cancer risk assessment in young women. So Sacha, you're the principal investigator for this study. Please could you tell me about what this study is looking into?
So this study is looking at whether we can identify women at increased risk of breast cancer in their 30s, so from 30 to 39. And what we're trying to do is, by asking some simple risk factor questions, looking at the density of the breasts on a low-dose mammogram and doing a saliva sample for their DNA, see whether we can put all of those together to identify those who would be at risk in later life.
Amazing. And how did this study come about?
So originally, this kind of work has been going on in older women in Manchester since about 2010 with the PROCAS study. Now that was for women in screening over the age of 50. And it showed that we could identify women at increased risk with quite high levels of accuracy. So what we wanted to do was then bring that down to women in their 30s, where breast cancer is the most common cause of death in the UK.
And who are your funders for this study?
So this study is funded by CI UK and also by some charities, and also the Shine Bright Foundation, which is a small local charity.
And you've mentioned previously that you're looking into these factors through things such as saliva. So what are you looking for, and how do we identify these risk factors within this cohort?
So from the saliva, what we do is extract the DNA. And when we've taken out the DNA, we're then looking for some subtle changes that are either associated with a very slight increase or decrease in risk. But because we can now identify more than 300 of those, if you're somebody who's inherited lots of the ones that slightly increase the risk, then overall your risk can be significantly increased.
And what are some of the main risk factors that you're looking into within this study?
So the general risk factors for breast cancer are things like your period starting very early. So if you have a pregnancy over the age of 30, that would also increase the risk. Things like the oral contraceptive pill will also increase the risk of breast cancer. Those are the kinds of factors that we're asking women in the questionnaire.
And if this study is successful, what would that mean for women across the country of this age bracket from 30 to 39?
So this is a very successful study, and we are able to identify that the density of the breasts is a strong risk factor in women under the age of 40. Put that together with the genetic risk factor and the questionnaires, that could then be rolled out to a situation where women would come at maybe 30 years, have their risk assessment, and then be planned to start their breast screening much earlier than they otherwise would, which is currently the age of 50 in the UK.
And Sarah, you focus on the psychological impact of this study. What are some of the harms that could be associated with taking part in this study?
Yeah, sure. So because this study is going to be identifying women without strong family histories of breast cancer, it is a possibility that women might find an increased risk result quite surprising and unexpected. So it might actually increase short-term distress in the form of anxiety and cancer worry. And secondly, because there might be some implications for women identified at increased risk in terms of decisions about having children. Some women may experience feelings of remorse or distress over their decision to take part in the first place. So we will be assessing this by using questionnaires at 3 different time points throughout the study. And that's going to include measures of anxiety, breast cancer specific worry, and decisional regret.
And Sacha, coming back to you, what are the processes in place for those that may identify that they are in increased risk of developing breast cancer?
So for the women that get the letter saying that they're at increased risk, they also get some additional information that describes that in more detail. And then we invite them to an appointment for review at our Family History Risk and Prevention Clinic at Wythenshawe Hospital. And in that, what we'll do is go through in some detail why the risk is increased, and then what we can do about that in terms of starting screening earlier and even considering some risk-reducing approaches. That might be diet and exercise, it might be avoiding alcohol, and it could even be risk-reducing medication.
And Sarah, coming back to you, how will you assess the acceptability of implementing this risk assessment for all women ages 30 to 39?
Yeah, so when we refer to acceptability, we're talking about how women receiving a healthcare intervention feel about it and what they think about it and how much they consider it to be appropriate based on their experiences of participating. So in this case, the healthcare intervention would be breast cancer risk assessment, and we're interested in knowing how acceptable that is in young women. And it's important to consider acceptability because if the processes of invitation, risk assessment and risk feedback are not acceptable, uptake will be low, and then the potential benefits that Sacha's outlined may not be realised. So we will be assessing acceptability by interviewing approximately 24 women who take part in the study about their experience of the risk assessment. We will ask them to reflect on the process that they underwent to have their risk assessed, and in terms of how it was delivered and the information and the support that they were provided with, so that we are able to identify any changes that we need to make to the offer of risk assessment in the future, to hopefully make it as acceptable as possible and therefore increase the likelihood of women engaging with it in the future.
Incredible. And how are the team considering health inequalities within this study?
Yeah, so previous research, such as the PROCAST study that Sacha mentioned, which implemented risk assessment at the age of breast screening, which is with older women, that actually found that women from ethnic minority populations and more deprived backgrounds were less likely to take part in that research. So therefore it's important for us in this study to consider the potential for exacerbating existing health inequalities. And we intend to look at that by comparing uptake rates by both deprivation and ethnicity between the women who actually participate in the study and the women who decline participation. And this will allow us to see whether a primary care coordinated invitation process is successful at engaging women from diverse backgrounds. And if it isn't, then we'll know that we need to consider and evaluate different invitation methods in the future.
Incredible. And Sacha, you were the consultant for Sarah Harding, the Girls Aloud star, who recently passed away from breast cancer. Was she diagnosed at 39? What do you think she would think of this as kind of some of her legacy? I know a lot of the funds have gone from her foundation have gone towards this study.
I think she would be thrilled. We spoke about this research during her year or so that she had a diagnosis of advanced breast cancer, and she was quite passionate about supporting the research and any money raised after she died going towards it. So I think she'd be absolutely delighted that we're up and running and recruiting really well.
And finally, what would your ask be to policymakers listening that would hopefully change kind of national guidance on breast cancer screening?
So currently in the UK, we only identify women at increased risk of breast cancer by their family history. And that's probably around 4 to 5% of women are eligible for enhanced screening after they've had a strong enough family history identified. But about 2/3 of women who develop breast cancer don't have any family history at all. If we use the kind of approaches we're using in BCAN-RAY, we can identify nearly 20% of women who are at increased risk level, at that level where they could have enhanced screening and preventive approaches. So my message to policymakers was, let's start rolling that out now, certainly in women at 40 and above, and if we confirm that the effect is strong in the younger women as well, then from the age of 30.
And thank you both for coming on and speaking with me today about the BCAN-RAY study. It's been great to hear all about the breast cancer risk prediction in 30 to 39-year-old women. And it's great to kind of forecast what the effects could be for people across the country. And I look forward to the next 5-10 years hearing about the developments.